All right, wow, this room is so full and I'm impressed because I never come to things like this. And I see my undergrad, some of you, and I definitely did not come to things like this when I was an undergrad. So it's really nice to know that you're not following in my footsteps, and I am sort of like a little embarrassed and now convicted over my absence at these sorts of events. I will try to repent in the future going forward. It's exciting. I see some of this is like a little reunion of my public policy class last year, right? There are a bunch of you here. That's really interesting. You're probably just gonna yawn and be like, oh my gosh, all she did in class was teach us all about the stuff she does anyway. Yes, that's the trick, basically. That's how I teach more efficiently, which those of you who were in class today, we talked about efficiency. Okay, so good to see you all. I miss you all. There's something popping up here. Okay, it's gone. All right, so I'm gonna dive right in. There's really two versions of this talk that I give, which I've given a lot of over the last year plus since the book came out. There's what I call the political science version, which is like, let me tell you my research questions and my hypotheses, and let me tell you all about my data and going into deep detail about it. And then there's the other version that I've been giving to sort of what I call more ordinary people, so health policy advocacy groups, hospitals, hospital associations, policymakers, and it's just a little bit more concrete, a little bit less abstract. And that is the version I've opted to give today. So for the political scientist in the room, happy to answer questions if you want more details. But for everyone else, you're welcome. I saved you from having to listen to me spout off my hypotheses and tell you information about my data that you don't need to know. I am happy to answer questions in more detail, and I'm going to make sure I leave time for that because it's always the most interesting piece. So we're starting with this slide, which is the actual cover of the book, and then the cover I wanted. But my editor was like, but she looks so mad. And I was like, exactly. That was the point. And apparently we just didn't see eye to eye on that. So I did want the cover to sort of center people of color, women of color, and action, political action and engagement. So I was happy with the cover that I ended up with, but I still love her, right? And I just like literally have this on the desktop of my computer. So I've never included it in a talk before, though. So thank you for giving me an excuse to do that. And grad students, I feel terrible that you all felt obligated to come here, but happy that you're here. It's conflict of interest. Okay, let's jump right in. The health policy roller coaster. We've all been on it in the United States for the last several years. I know the last 9 or 10, going on 10 years. I know I've been exhausted by it. The Affordable Care Act, for many people, myself included, it was, yay, the Affordable Care Act, we're making some strides. That's not how everyone felt, obviously. But it happened, right? And in 2010, we got the Affordable Care Act. And for many health policy advocates, there was this sense that there was a new set of possibilities on the horizon, and maybe we would approach something like universal coverage, or at least we were coming closer to reaching that, right? And then other things happened. The political context, it's a moving target, it changes, right? And we just saw attempt after attempt after attempt to repeal the Affordable Care Act. And there are always these great creative names, and my public policy students know we talk about what policies are named and how significant that sometimes can be, and how, you all know I have pet peeves, how exhausting the names can sometimes be. And so I call it the alphabet soup of repeal and replace, lots of them, the BCRA, the AHCA, the AHA, it's all just way too much. But it's the same theme, that this is a really contentious policy area and one where we've seen a lot of change, right? And a lot of debate. I will tell you, honestly, when I first started working on what was going to be the seed of this book project, when I was in graduate school, I wasn't really into this. I mean, it wasn't really happening yet at that point. It was about to. It was roughly 2009, right? But I wasn't into healthcare more generally. I went to graduate school because I wanted to study politics in the communities that I myself came from. I wanted to understand how people who lived in low-income communities and immigrant communities and communities of color were experiencing the government, how they were interpreting it, how they understood it and talked about it. That's what I went to graduate school thinking. And I didn't necessarily think about it through a policy lens, so it wasn't that I cared that much about health policy per se, right? Oh, not yet. But then something happened. I had, a lot of things happened. But I had a great person on my dissertation committee who, this doesn't mean anything, but it wasn't a political scientist. It was a sociologist. And he did qualitative research. And I sat down one day, I was really struggling to figure out what my dissertation was going to be about. And I said, I just don't know. And he said, okay, well, what do you care about? And I told him what I cared about, and it was something like what I just told you, right? I really care about understanding politics in the communities that I feel like are the places I came from. And I don't exactly know how to think about that in terms of the political science lexicon, but I know that's what I care about. And, I gave him some ideas. I said, for the sociologist, it was Mario Small. I said, maybe this, maybe that. And Mario said, it feels like you're just plucking things out of thin air. Like, instead of deciding a priori what matters to these communities, why don't you just start by talking to people? And then people can tell you what matters. And then your research can be focused by the actual communities that you care about. And he said, some people come to graduate school knowing the topics they want to study, and other people come just knowing what they care about. You're one of the knowing what you care about people, so follow that thread. And I did that. I started to do interviews with people on the south and west sides of Chicago, which is where I was in graduate school at the time, in low-income communities, and talk to them about what was important to them in their lives, right? This is these are all pseudonyms. They're not real people's names, but the names do start with the same first letter, right? So this woman's name starts with an M. It helps me to remember and keep track. Mabel was one of the first people that I interviewed in Chicago when I started to do this. These were open-ended interviews, and one of the questions that Mario Small suggested I ask was something kind of apolitical. Tell me what you think about the American dream. It's not really apolitical, but that people wouldn't read on its face as blatantly political. And this is what Mabel told me. I don't know anything about the American dream. She starts talking about the American nightmare, right? And one of the things she talked about was Medicaid. This was before I knew that this is what the project was about. So I didn't ask Mabel about Medicaid. She talks about having to make trade-offs between food and her pills, right? Her medicine. And she talks about going to try to receive resources via Medicaid and being really discouraged and literally deciding, and Mabel's a diabetic, but she decided it was such a negative experience that she didn't want to have to deal with Medicaid. And at this point, her sons, who are older and grown up at this time, she's in her early 60s, are helping her pay for her insulin, right? But it's a stress, it's a financial stress, and it's a psychological stress. And earlier in the interview, I'd asked her what she thought about government, but it wasn't connected to this question, but she comes back to it, and she says, that's why I don't know. When I asked her what she thought about government and politics, it was like crickets. She was like, I don't know anything about that. I don't care about that. But then when I asked her about the American dream, and when she started talking about healthcare, she did have some thoughts and opinions, right? She's like, look, this is why I say I don't know and I don't approve. It's like we do things, we try to do things, we vote, and it's supposed to be making a difference, but it doesn't, right? This was a super depressing interview. But one thing that I noticed in the initial set of interviews that I did, before I knew that the project was about health policy or about Medicaid specifically, is that people kept bringing it up. And so I hit a point where I realized, I wrote my dissertation. It wasn't really about Medicaid. I did have one chapter about Medicaid. But when I looked back on what I wanted to do as I moved forward, I realized that this was the piece that was crying out for the most intervention, where people cared a lot. It was affecting their lives in really profound ways. And some of the moments in my early interviews where I was most moved were around people talking about healthcare. So I decided that that was the direction I was going to focus on. And since I'm a political scientist, I wanted to think about how Medicaid mattered politically, right? Now, some people, when I initially started to talk about this idea, were like, matter politic? Like, it's people's health care. It's not going to affect their politics, per se. Now, this is what non-political scientists are saying. The connection isn't necessarily obvious. So part of what I draw in my book is how it is that participating in a program like Medicaid actually has an effect on your democratic citizenship and your ability, your willingness, your inclination to participate in the polity. That connection might be obvious to some of you. Some of you took my public policy class, so of course it's obvious to you because we've talked about it. But it's not obvious to everyone. And I was sort of astonished at the number of people, as a graduate student, I'm sure the graduate students can relate to this, random people ask you what you're working on, Then you try to tell them and they look at you like you're crazy. And that's a lot of what I got early on in this project. But Medicaid does matter politically, right? And that's what my book really draws out. So a big part of my motivation for focusing on Medicaid is that all of my research really is located at the intersection of thinking about race, poverty, and democracy, right? And Medicaid is a great place to think about that intersection, right? Here's an intersection, this is what I found. This is also sort of depressing and dark, I realize, but it's relevant. 90% of non-elderly Medicaid beneficiaries are living in or near poverty. So they're either below the poverty line or they're within 25% of the poverty line. So the vast majority of people, if they're not elderly and they're not severely disabled, but they're receiving Medicaid, it's because they're very poor, right? 50% of Medicaid beneficiaries are either Black or Latino. This is not reflective of the population more generally, right? So the program is disproportionately relevant to people of color and people living in poverty. So for me, that's actually appealing because it's a lot of what I care about, grappling with how inequality in our social and economic life maps onto our democracy, right? And trying to think through that in terms of mechanisms. How are those things connected to each other, right? It may seem sort of intuitive to us that they're connected, but until we know, it's difficult to figure out how we can think about something like intervention or change, right? So I want to understand how Medicaid matters to people politically. Like, how do I figure this out? So initially I was like, okay, I'm going to find some data, some evidence out there. I'm looking for surveys I can use. It's actually pretty difficult. There aren't that many great surveys, at least that political scientists tend to use, that are both asking people about their experiences with different social policy benefits and asking people about their experiences with policy and politics. And so it took me some time, but eventually I encountered the Fragile Families and Child Wellbeing Study, which I know that the sociologists in the room at the very least are familiar with. And it's a really unique study, and so you can think of that as a strength and weakness. I'm happy to talk about how to think about that trade-off. But Fragile Families actually follows a cohort of 5,000, 500 would not have worked, 5,000 children and their parents, right? It's not representative in the sense of a nationally representative sample, but something to keep in mind is that most nationally representative samples don't actually have large groups of the kinds of people I'm interested in studying, right? People who are living in poverty, people of color. So it's not nationally representative, but it does represent the populations of interest to me. So I focus on wave 3 because that's the wave where I get the political questions and I get the questions about social policy. And during this wave, which covers people in the area of about 2001 to 2005, that time frame, 53% of the people who took the survey, which was about 7,500 people, reported using Medicaid, right? So that gives me several thousand people who have relied on the program and also people who have not. Many of these folks are similar in terms of their life background. And so there's some things that I get to hold constant and a whole bunch of information that the survey gives me about the people who I'm trying to understand. So originally, I just want to understand in a really basic correlational sense, is using Medicaid connected to or correlated with your political behavior, right? So this is just basic correlations. And what I find initially is yes. Yes, it looks like it is, right? So if we look at the dark bars, those are Medicaid beneficiaries, and the slashed bars are non-beneficiaries, and it looks like Medicaid beneficiaries are lower in terms of their voting, their likelihood of registering to vote, and a kind of metric of participation that's more broad than that, right? Have you participated beyond voting and registering to vote in these other political activities, like being a member of a political group, being a member of a local neighborhood or community group, or neighborhood watch, a whole range of other things. And across the board, it looks like Medicaid beneficiaries are less likely to participate than non-beneficiaries. That's not actually that mind-blowing, because these people are living in poverty, and they tend to be disadvantaged in a number of ways. So maybe if we account for that, this disappears. And it's not about what Medicaid is doing or how Medicaid is affecting them. It's just about the distribution of people who happen to rely on that program. And perhaps these people are themselves just less likely to participate for a variety of reasons that don't have to have anything directly to do with Medicaid. So I pursued several different analytical routes to try to get at that. And like I said, this is my regular people version of the talk. So I'm not going to go too deeply into this, although I'm happy to. Standard regression, which is just controlling for a whole bunch of things, right? What if I control for education and for employment and for income and for whether or not you've gotten other social policies and for your civic attitudes and everything under the sun that I can possibly imagine? It doesn't make the relationship go away. What if I expand and I think about things that are particularly relevant to people who are living in poverty? Drug and alcohol dependence, depression, experiences with incarceration. Maybe you have larger families. Maybe you're less likely to be married. It's the Fragile Families and Child Wellbeing Survey, right? So we can also expand the models and control for those things. It doesn't matter. Matching. What if I find the Medicaid beneficiaries in the survey, the non-beneficiaries in the survey, and try to match them on as many indicators as possible? So they're as similar to each other not every way, but in many ways that I can observe, right? With the exception being that one set of those folks are Medicaid beneficiaries and another set aren't, right? What do I see? I still see a strong relationship between political participation and Medicaid enrollment. And then this last method is really about trying to account for the fact that maybe there's something about the people who apply for Medicaid that's unique, right? So if we have people who are like, we're both poor, we're both low income, we're both living in a low income neighborhood, we're similar in all of these different ways as in this sort of match scenario, but I didn't apply for Medicaid, I didn't get it. Well, then why? Maybe there's just something different about me, right? If I did apply, maybe I'm the kind of person who's more likely to ask for things or who's more likely to be a negativist and sort of there could be distinct things about people who are willing to apply for the program, and that might be, so your selection into Medicaid might be what explains why the outcomes are different and not your experiences with the program itself. Even if I account for that, and I will say, you can't account for any of these things fully, right? You do the best that you can. Ideally, some people would say if we did like some kind of randomized trial, it would be great. They did that in Oregon. And I asked them for the data and they wouldn't give it to me. So there, I tried. I ended up with these results. I actually initially started to get some results, initially using other surveys when I was in graduate school. And then afterwards, I found Fragile Families. I used that survey and I was like, wow, these results don't go away. And I would tell people about it and they'd be like, well, why? And I realized I didn't actually have a good answer. And the reason I didn't have a good answer was because Fragile Families survey couldn't tell me that, right? In order to figure out why, in order to understand the mechanisms, the processes that were accounting for why Medicaid beneficiaries seemed less likely to participate in politics than non-beneficiaries, I had to actually talk to people, right? Which I'm a people person, so I didn't really mind so much. So I spent some time during a postdoc that I did after graduate school, interviewing Medicaid beneficiaries all across the country and asking them about their experiences with the program, and trying to get a sense of how their experiences with the program affected the way that they thought about, understood, and engaged politics, right? So I interviewed 61 people, 45 Medicaid beneficiaries, and 16 stakeholders. So who are the stakeholders? The stakeholders are generally people who are connected to Medicaid beneficiaries in important ways, but not beneficiaries themselves. The reason I included the stakeholders, a couple of different reasons. One thing people would say to me is, anytime you talk to people about a program, they're going to say negative things. You talk to me about my insurance company, I hate it. Talk to me about the DMV, I hate it. Like, you're just going to get this biased inclination towards people complaining about any program they're a part of. Now, that's not actually true. And I realize that now more than ever because I'm doing some research on some different programs like WIC and SNAP, which colloquially known as food stamps. And people actually recognize differences across these programs, and they're not just complaining about every and anything that you ask them about. But there is this sense that, can you really trust when people tell you that this is how they understand a program, that what they're telling you is right, right? I err on the side of saying yes. You can talk to people about their experiences, and you can trust what they tell you about those experiences. But I thought it would be also useful to sort of complement the core interviews with interviews of people who aren't Medicaid beneficiaries themselves, but who are interacting in sort of pretty intense ways with beneficiaries. So some of these people are healthcare navigators, so they help beneficiaries not just to get signed up for the program, but to navigate the challenges that emerge as they're part of the program. and quite a few people from healthcare advocacy groups who work in communities with Medicaid beneficiaries, trying to help them to advocate for expanded resources. And then quite a few lawyers, people who represent Medicaid beneficiaries when their benefits are cut off or when they have some sort of problem with the program. So a range of different people. Now, sometimes people are like, you only talk to 61 people. Like, that's not a lot. And to those people, yeah, the qualitative people in the room are like, who says that? A lot of people say that. But as far as qualitative research is concerned, it's worth remembering that the point of this research is different, right? The point isn't to go find a representative sample, talk to a whole bunch of people and have them tell me something that can help me understand general patterns. The point is to understand depth and to be able to understand mechanisms and processes. And what that means is that you have to really get in there with people, and one conversation that lasts an hour or 2 hours can illuminate a ton, right? From that one conversation, you might have 50-page interview transcripts, right? And then you multiply that across people, and you also learn as you go along. The interviews were sequential. So based on what I learned from the early interviews, I added questions, and I used that knowledge to generate better ways of interviewing people and more in-depth ways of interviewing people later on. So there's a ton that you get from doing this many interviews, right? It's worth saying that because a lot of people are like, but that number looks low. You need at least 100 people. Here's the thing. It's not a random sample. So the difference between 60 people and 100 people, that doesn't actually mean anything statistically, right? The point is the depth, which I certainly got. I also aimed for range in terms of race, categorical group, and geographic context. Now, the categorical group is just about how you end up qualifying for Medicaid. You qualified because you were just a very, very poor adult, and so you qualified, or were you a pregnant mother, which would make it easier for you to qualify. I talked to parents, for example, whose children were on Medicaid and who therefore were interacting with the program but didn't qualify themselves. All of these different categories of people have different kinds of experiences and will approach and think about the program from different vantage points. So I wanted range there. And the goal was really to explain the quantitative patterns I found, generate new ideas and hypotheses, right? So this is initially what I find from the interviews, a broad story that I think really comports with a lot of what we see in political science. And it's really a story of stigma and a story of kind of bureaucratic disentitlement. So people are generally saying negative things about the program, and they're stigmatized by being a part of a program that is for people who are living in poverty. They feel embarrassed. They feel like they're treated like animals, like they don't know anything, right? They feel like you have to bend to their rules. You don't really have any power. And they talk about stigma. They talk about being embarrassed by the program. And then negative bureaucratic interactions are what some social scientists might call bureaucratic disentitlement. You know, they just talk about all of the paperwork, all of the red tape, just how hard it is to be able to be a part of a program like this, right? How rude people sometimes are in your interactions with them, and how ineffective street-level bureaucrats can be at communicating with people who rely on a program like this. So at first I thought, like, okay, maybe this is why, right? And it makes sense. We have some research that political scientists have done, for example, around cash assistance, where they found similar patterns. And, well, Medicaid is really different than cash assistance, but apparently I'm finding similar patterns, right? So one of the things that people would ask me really early on when I started talking about this is like, oh no, where are you going? Are you saying that Medicaid is bad for democracy? Paul Ryan is gonna love this. He's gonna eat your book up. Look, we need to cut this thing. It's bad for democracy. One thing I try to be really clear about saying at the beginning of the book is, well, basically a more sophisticated version of this, right? That's not the argument. It's not the argument because what the interviews further revealed were why, right? Why these experiences were happening and why they were leading to a dampening of political engagement. And what that helped me to understand was that this wasn't an inevitable outcome of a poor program for poor people. It was about how the program was designed and implemented, meaning it could be changed, right? And not changed through retrenchment, but changed through other means that wouldn't mean taking away resources from people who need them. So I started to encounter narratives that were unexpected for me. I sort of expected the stigma narrative, the bureaucratic disentitlement narrative. It's what I had seen in other places. And it fit with my perceptions of what I might find going in. And then there were people who just changed those perceptions, right? So Terry was one of the first people who I could think of this way. And I opened the book with Terry because I remember how struck I was by my conversation with her. I met Terry in Georgia. I went there for a week just to do interviews for this work. She was maybe the second or third person that I had interviewed during my time there. And I would initially go to a Medicaid office, a local Medicaid office, and literally, and if some people could not do this, but I don't have any kind of like people fear. So I would just stand outside of the office and like walk up to people when they came out and start asking them if they were willing to talk to me, right? I had some other ways of doing it. I had some contacts. I did some snowball stuff. I had other ways of finding people. But Terry was one of the people who I just approached. And I would have some systematic method of deciding who I approach. It'd be like, every fourth person who comes out the door, right? That way I didn't just go up to people who looked like me, who I felt more comfortable with. I had to force myself to go up to whoever that fourth person was, right? And Terry was one of those fourth people. I met her outside of a Medicaid office in Marietta in Georgia. And I asked her if she'd be willing to talk to me. And she said, well, I can't do it right now, but do you have time tomorrow? And I said, sure. We determined a place to meet. We met to talk. All I asked her was whether she talked to me about her experiences with Medicaid. So when we meet up, I literally say, hi, tell me about yourself. That's all I said. She has no context. And also at this point, the book is not about federalism, by the way. And Terry says, my name is Terry. I have a 16-year-old son. He'll be 17 soon. And instantly, I traveled a lot. So the difference between state to state with Medicaid is what it offers and the programs and how consistent they are. I have a lot of experience with that. Being in Medicaid 17 years, it's just been a whirlwind keeping my son safe and healthy. And I thought, oh, interesting. She's talking about how it's different. That's interesting. That seems theoretically interesting to me. I don't realize yet that this is really important. But Terry goes into detail. Ohio's the easiest. They really care about people. I was like, really, Ohio? Look, you can't judge. Just who knows? California, their process is faster, but there's so many people. It's rapid. It's out of control, right? Georgia, which is where we were, there are limitations on everything. You can only go to this doctor on this day at that time. And other people I interviewed in Georgia reiterated this, right? And then Terry tells me about her grandmother. She starts to get teary-eyed. I'm like, oh my gosh, what are we talking about? Like, what's the sad thing? And she says, when I knew I was going to meet you, I actually got upset thinking about it. I have a lot to say about Medicaid. And she tells me the story about her grandmother coming from Chicago the week prior. And her grandmother got sick while she was there, went to the hospital. They prescribed medication. And they realized, because her grandmother's a Medicaid beneficiary, that Medicaid in Illinois is not going to pay for medication in Georgia. So they're scrambling to figure out, how are we going to get money to pay for my grandmother's medication? And she ends by saying, that was amazing. For something that's provided by the government, you're limiting the use of something meant to make people better. So instantly I thought, wow, this geographic differentiation has crystallized for her into an understanding of what the government is up to, right? And for Terry, it was political, without me having to tell her so or ask her specifically about that, right? She tells me, well, if it's about helping people, I'd say, yes, let my state be more productive and healthy so we don't have people losing their lives, so they can be productive citizens. So I asked Terry, well, do you think you or people like you could do anything about this? You think you have any power to change this? And she looks at me and says, white noise. And I didn't have any idea what that meant. But in interviews, silence is productive. So I just sat there and looked at her. And then she didn't say anything. So then I said, okay, what does that mean, right? And Terry says, white noise is the people that choose to say, well, if they give it to me, they give it to me. If they don't, they don't. White noise also means that you feel like in your world, you have no say in the process if you don't agree with what's going on. It's the meaning, the process, not the benefit. Not having to rely on the government for health insurance, not anything about what you're getting from the program as far as benefits, but the process. She says, I've never really seen anybody stand up And I don't know why we don't fight. I continue to encounter narratives and people who would talk about place without me having to bring it up. And because initially, remember, federalism to me is like a dusty old thing. Like, I remember being in my grad seminar and reading the Federalist Papers and being like, oh my gosh, how am I gonna stay awake? That's not how everybody feels about federalism, but that's initially how I felt about it. So it wasn't in it wasn't on my radar that was gonna be a core part of this. I thought, like, sure, people are gonna get different things in different places. That's the way this works. I just didn't realize how important it was. But then people told me how important it was, right? And they told me without me asking them to tell me. This is John, right? I asked John how he's doing. I'm not where I want to be, but I guess beggars can't be choosers. John is a middle-aged white man. Most of the people that I'll show you, that I've shown you on these slides so far and that I'll show you going forward, are people of color. Mabel, the first person I talked to, is an African-American woman in her early 60s. Terry is an African-American woman in her early 40s. That's just the disproportionality of the program. Those are the folks who are relying on this program most. And their experiences, and I get into this in the book, are distinct, right? So it's not just about, well, this happens to be who's on the program. There are distinct aspects of this that are racialized, but it's not limited to that. So John is a middle-aged white man who has a chronic illness. That means that he's always going to need really expensive health care, right? And so he relies on Medicaid. He's able to get covered through Medicaid because of his chronic illness, and his chronic illness also prevents him from working. So even though he grew up with a sort of middle-class lifestyle, his parents were sort of, he describes them as a middle-class family, he now struggles because he can't actually work for himself. And he says, I'm not where I want to be. Beggars can't be choosers. And eventually, he talks about wanting a kind of federal insurance program. Everybody having insurance regardless of where they live. And he explains his logic. So a lot of what's behind this is that a lot of John's family had moved to Arizona, right? John, at the time I interviewed him, he lived in Michigan. And his doctor told him, actually, the dry climate in Arizona would probably be better for your health because he had a lot of lung issues. And he thought, my family members are moving there. It'd be great to move there. I could get out of Michigan. But when he did his homework, because he realized he relies on Medicaid for life-saving health care services. So he did his homework, and he checked out Medicaid in Arizona, which, by the way, Medicaid in Arizona is called the Arizona Health Care Cost Containment System. You can't make this stuff up. That's what it's called. And so, not surprisingly, John figured out that he probably would not qualify for Medicaid in Arizona as a childless man who was low income, but didn't fit into their much stricter version of medical eligibility via medical need. He just wasn't going to qualify. And he realized, I can't move. I can't go anywhere. He talked about being married to Michigan medically, right? And how that affected his whole life, the whole way he thought about his prospects for upward mobility, his freedom and autonomy, right? John, Terry, they were really the tip of the iceberg. They were some of my early interviews. And the more people I interviewed, the more I realized that place came up. People talked about Medicaid in terms of states. They talked about it in terms of counties sometimes, even down to neighborhoods. But it mattered where people were located. And that's a function of federalism, of the way that we design our social policy system that allows place to have the power that it has in our country. And so I decided to go back to the quantitative data, because initially when I had analyzed the qualitative data, I just kind of controlled for what state people lived in, but I didn't really think of it as a crucial factor. So I looked at the Fragile Family Surveys. I identified 15 states where there were more than 200 people in the survey so that I could do some relatively useful subgroup on the state level analysis. And I wanted to see what I'd find if the relationship between Medicaid and political engagement varied across state. And I found that it does, right? In some states like New York and California and Virginia, that relationship is negative. In a lot of states, anywhere this is crossing the red line, there's no correlation. And then Wisconsin, which I thought was so weird, if you know anything about Wisconsin Medicaid now, there's a positive relationship, although this is 2001 to 2004. And at this time, Wisconsin is actually leading the country in terms of allowing people to qualify anyone who is below the poverty line, right? And at that time, even if you're an adult, even if you're childless, what have you. So Wisconsin was doing something very different than it's doing now. So I thought, oh, this is really interesting. It's not really what I expected. Like, I mean, some of the states that I might have thought would be like potential bad actors don't really pop up here in that kind of way. And so I really wanted to understand why, right? And in particular, I wanted to try to grapple with what is it about state policy context that's driving this relationship, right? It's not that people in like New York are more ornery, and so like they're just mad about their negative experiences with Medicaid there, but not in, as a New Yorker, I want to say that can't possibly be the explanation. And so what is the explanation? So I go back to my interview. So this is a real multi-method project, right? I figure something out from the quantitative work, and I turn back to interviews to try to get a sense of that. And then I return to the quantitative work, but I look at it in a different way, doing analyses I hadn't done before to try to see if now something can be illuminated for me. And I go back to the qualitative work to see if what the new information that I found in the quantitative work holds up, right? And along the way, I'm expanding the sort of ambit of the qualitative and the quantitative work. So I now, both in the interviews I'm continuing to do, and I go back and I recode the interviews that I've already done to figure out, are people giving me indications about which elements of state policy context matter? And it turns out they are. They're telling me a ton. I just don't realize this initially, right? So one of the things people are talking about all the time is expansion and retraction, right? How much the policy is always changing. The policy is changing. It's hard for anybody to go to a doctor now. You can't even get a general PAP or any kind of exam, right? These are all like examples, but these are the things that people are consistently saying to me, right? So policy changes, either expansions or retractions, are noticeable to people. When you have something and it's taken away, or when you now have something that you couldn't have before, guess what? It stands out to you, right? People are logical and rational. They know when they're getting more and they know when they're getting less. So that's really something important that people are bringing up again and again. But probably the primary thing that people bring up. Scope of services is a big thing. People get into me about in the weeds, the details, like, well, in Georgia we have WellCare, and that means I pay 30% for dental, but vision is free. So we have bad eyes, so I like the free vision and the 30% for dental because we have great teeth. You see what I'm saying? We have no cavities, so I picked that plan. So in Georgia, you can pick one plan where dental is going to be free and vision you'll have to pay for, and there's another plan where vision is going to be free and dental you have to pay for. And people are having to figure this out. Well, we have good eyes and bad teeth, so and so now people are just they're in the thick of this, making these choices. But you're not going to have it all. And I actually am echoing a woman who, in the book, I call her Nina, a black woman who said, I just remember her really clearly because she looked at me in the interview and she said, you know what I'm saying, right? You know what I'm saying. She's like, we're not going to have it all. They're not going to let us have it all. It's going to be one or the other, right? And so people are really made aware of this because they're forced to make choices about it. And it's on their radar. It's very salient. And administrative capacity. You know, people said again and again and again, there's just not enough caseworkers. There just aren't enough people to process us. And so you walk into the Medicaid office and it's just going to be frustration. It's going to be frustrating because we just don't have the capacity that we need. So I went out at this point to try to collect quantitative markers of these indicators of state policy context, right? Has the state expanded or retracted benefits in the past year or past 2 years? What is the scope of services? Do they provide dental and vision? So I looked at all the additional services states provide that the federal government doesn't mandate, right? Because Medicaid is an intergovernmental program. There's some baseline suite of services that everybody has to get because the federal government says so. And then there's this huge array of things that states get to choose. You know what? We don't think physical therapy counts. Podiatry, come on, you're going to be fine, right? Down to, right, your feet hurt. Come on, give me a break. Take a hot bath. Down to what services can get done to your teeth, right? So I interviewed a woman who said, well, I had a lot of cavities and the doctor removed the teeth, but Medicaid wouldn't cover the doctor putting them back in. Right? So she's walking around until she could save the money for the dentures with the front row of her teeth missing, right? And it's almost ridiculous. Like, you could chuckle, but she's like in tears telling me about that week of her life and how she didn't want to pick her kids up from school because it was embarrassing. And she didn't want to leave the house because she was embarrassed. And this is not everywhere. This is states deciding, well, if the teeth's bad, pull it out, but we're not paying for dentures, right? Down to literally from birth, right? I had people telling me about their kids in the hospital. One woman told me about her daughter's tonsils getting taken out, and she asked the nurse for ice, and the nurse said, "Do you on Medicaid?" And she said, "Yeah." And the nurse said, "Well, you don't get ice." Now, that's not written into policy, right? But that's about how Medicaid beneficiaries are being engaged, both formally, in terms of the policy context, and informally, right? Down to death, right? As a child, and as even when it comes to hospice care. If you're an adult who's dying and you're not elderly, there are some states you're not going to get hospice care. You're not going to get any relief in that most painful, difficult moment of your life. People know this, either because they're experiencing it themselves or because people they love experience it. So I had someone who said, my dad was on hospice care and they wouldn't give him morphine. They wouldn't give him drugs. And so he died in agonizing pain, right? People make all types of sense of this. And it affects how they're understanding their relationship to the government, right? That particular woman, she was convinced, and I'm not saying that she's wrong, that it was because they were Black, right? Now, I could say, actually, that policy on the state level is, right? It was actually a state level policy decision, but who's to say that those state level policy decisions aren't related to things like race and class? Because we know that they are. So she wasn't necessarily wrong. But now you think the government cares about me so little that in the most excruciating moment of my life, I don't get taken care of. And it's because of my class, and it's because of my race, and it's because of my subordinate standard. Now, how are you going to engage that government? How are you going to behave politically, right? It makes perfect sense. And it's not random. It's about specific policy contours that we can identify. So this is just one example. You know, if we look at states that are reducing benefits given to Medicaid beneficiaries versus those that aren't. So states that have reduced benefits in the past year versus those that aren't, and we hold a lot of other things constant and we compare how Medicaid beneficiaries behave in one set of states versus another, we know that the probability of registering to vote, of voting, and of broader forms of participation are all declining along that axis of how much states have reduced what Medicaid beneficiaries have access to, right? I'm going to go over this really quickly because I can't talk forever and I want to wind up. But the book also looks beyond states, and I think about counties and neighborhoods, largely because people are talking about counties and neighborhoods. In particular, people talk about county bureaucratic structures and how, when things go wrong, when you go to apply or when something goes wrong, what happens, right? Are you going to initiate a fair hearing? How are you going to react and behave? This is a different form of political engagement. It's not voting. It's about how you respond within the context of the government institution to try to get what it is you need. And it turns out that there's state and county level variation around these processes as well, and around how people are engaging, whether they're likely to appeal, right? And then neighborhood context, I have a chapter on this, and it's really important. This was especially true with the Black and brown folks that I talked to. They did not talk about Medicaid in terms of like in abstract terms. It was like literally instantiated in their neighborhood. They talked about the clinic up the street. They talked about the drug dealers on the corner. They talked about crime. And these are, it's not that like, you know, contrary to what our president believes, it's not that all Black and brown people are dealing with these challenges, but the kinds of folks who end up relying on Medicaid disproportionately are. And so they're thinking about how Medicaid affects them through the lens of their neighborhoods, right? And at the beginning of the book, I talk about a woman named Daphne, who, when I ask her about Medicaid, starts talking about her neighborhood. And at first I'm like, what? People are getting distracted. Like, I'm not asking you about your neighborhood. And then I started to pay attention. I realized that when you go into that clinic and on the way there, you feel like the cops are following you and hanging out around there, and then you go in and the paint is peeling off the wall and you're like, I wonder if I'm gonna get asbestos, and then everything's dirty, and that actually affects how you think about Medicaid and how you then evaluate Medicaid and your importance in relation to a program like this. I also focus on key actors, policy advocates and activists, and how they think this kind of fragmentation and variation across place affects what they're able to do. And they say, actually, when we want to build coalition, when we want to bring Medicaid beneficiaries together to fight for expanded policies or to fight against retrenchment, it's actually much harder to do in the system. But that's not the only story. Some advocates and activists talk about how they can leverage federalism and state and local fragmentation and variation. So it's a complicated story in this realm. I want to wrap up and just end with some key takeaways. Medicaid has differential political effects across states, counties, and neighborhoods. I call this in the book the model of contextualized policy feedback, but you know, that's just extra lingo that I held back for your own sake. Federalism, which I once thought was this dusty old boring thing, it turns out I was really wrong, right? Because it manifests in people's lives. It affects how they experience their world. It structures the relationship between policy and polity in ways that are really crucial for us understanding the nature of democratic citizenship in our country. But federalism isn't the problem. It's not a problem in any inherent way. There are other countries that have federalist systems that don't see these kinds of disparities. It's the vehicle through which our politics operates, right? Political scientists, policymakers, et cetera, I argue in the book, and I argue now, need to keep the democratic consequences of federalism in clear view when they're making policy decisions, right? Medicaid matters, health equity and political equity are linked. All right, that's it. Thank you. Questions?
Questions. We have about 10 minutes. So
I went over.
Figure out how to turn on the mic. And if you have a question.
Thank you. I'm curious if any kind of bright spots analysis has been done of the case of Wisconsin, for example, that you talked about, where there was a positive relationship.
Yeah, and it would be interesting to see if that still exists. Because Wisconsin has really led the way around things like drug testing and work reporting requirements, and is just on a completely different side of the spectrum now. I don't know of any in-depth analyses of Wisconsin, in part because there's really only a handful of people who are looking at these questions, but it would be quite interesting, I think. You know, I did publish a paper after the book came out focusing specifically on Tennessee, right? So that was a specific kind of case study approach. And Tennessee made a really explicit policy decision in 2004 that they were going to dramatically cut the program and reduce the benefits that they were offered under a Democratic governor who was like, look, we need to save money. And so went from being one of the most generous and expansive programs in the state to being one of the smallest and most pithy programs in the state in 6 months, right? So I do some pre-post analysis to look at how this affects elections, right? And in particular, whether we see more effects in counties where there are more Medicaid beneficiaries. And so that pre-post shows at least in terms of turnout, vote choice, who people are voting for, gets a little complicated there because it's a Democratic governor and it confuses people. They don't know who to punish. But it affects turnout, right? And so that we see in the election immediately following that decision, dramatically fewer people turning out, in particular in the places where there are the most Medicaid, where Medicaid beneficiaries are most concentrated. So there are some single case studies like the one I've done, but there's more to come, right? So, and I'm actually doing some work focused on what's going on in Wisconsin now, so more to come.
Hi, Jamila. Thank you very much. I really enjoyed this. I don't know if this is federalism or not, and I'm not clear on the time frame where you did this, but I'm wondering, with some of the states that accepted, that did the ACA Medicaid expansion versus others, can you address whether that emerged in either the quantitative or qualitative data?
Yeah, so the time frame is really important, and I should have mentioned that. So I actually stopped collecting data around 2013. So that's before most states have implemented the Affordable Care Act or expanded Medicaid. Luckily, we do have some research that's been done since then that looks at the effect of Medicaid expansion, and even more luckily for me, it is consistent with my findings. Don't you love it when that happens? And so what that research shows is, so remember what I said is expansionary policies tend to have a positive effect on political participation, and policies that are retrenchment don't. So the two studies that have been done since Medicaid expansion have shown, in one study they focus on districts, and another they focus on counties, and they try to take advantage of some place-based variation, or on states rather. And so expansion actually is a boon for the electorate. So in the wake of Medicaid expansion, more people are turning out, right? We don't have evidence that that's a lasting effect, that it's the case in the following, because there's like the expansionary effect where people are like, I got more stuff, I'm happy, let me go vote. But then they start to actually experience the program. And so the second order effects down the line can be really different than the immediate effect of expansion, which is an important distinction. And so the biggest papers have really focused on what happens when you give people Medicaid. And what happens is there's more voting. But like whether that holds, we don't have evidence for that yet. So good question.
Hi, Professor Michener. I'm sorry if you spoke about this last year in your class.
And you weren't paying attention?
I always paid attention. I didn't know what you're talking about. I was sort of jumping off that question. I was wondering if you had any logical justification as to why Medicaid, Medicare, or these social programs, specifically Medicaid, might affect voter turnout or political leanings. Like, for example, is it that people are simply healthier and so they're able to vote? Is it that a more generous program gives more favorable views towards the government or towards one political party?
Yeah, so, okay. One of the things that I do in all of at least the quantitative statistical models is try to control for health. So I don't want that to be the mechanism, because, I'm sure it is a mechanism, right? But it's not the one I'm most interested in. What I want to know, and what's reflected here, it's why I'm drawing on people's experiences, is what is it about Medicaid, besides the fact that it's giving people health resources? And the answer that I offer in the book and that I'd offer here is that it's about the political resources that people are being given or that are being drained from them, right? So it's that how people understand the government, their relationship to it, changes on account of the experiences that they have with Medicaid. And so that affects how they behave politically, right? And so it's affecting things like political efficacy, political attitudes. There's only 2 studies I can think of that have been done that look at vote choice, right? Whether it changes who you vote for, right? And that's a little bit complicated, in part because those are based on specific state level case studies, and there's a whole ton going on there. So the research on vote choice is really mixed, that it's not necessarily that it's changing your political preferences entirely in terms of who you vote for, but it's turnout that is driving these differences, whether you show up to vote and whether you show up to do other things in your local community. I'm really clear in the book about not restricting the way I think about politics to just voting, right? But the mechanism is that it's changing the way you understand yourself as a democratic citizen and the way that you understand yourself to be appropriately engaging in politics. If you think people would say this to me all the time when I interviewed them. I would ask them about whether and how they participated in politics. This was the modal experience. They would look at me like I was completely dumb for asking that question. I would then say, I'd let the silence linger for a little while and say, well, you don't seem to have enjoyed that question. What is it about that question and people would say, I always save that for the end because I didn't want to give people that lens at the very beginning, but they'd often say, do you hear what we've been talking about this whole time? I'm telling you about all these experiences. Of course, it's not at the top of my list to figure out how to engage in my community or how to engage the government, right? So people are explicitly linking these things and saying, I already told you all this stuff about Medicaid. Don't you get why now I'm not going to be able to tell you that I'm out there voting and campaigning, right? Those things are really connected for people, right? And so we can think about other mechanisms but maybe they're getting healthier but really what people are saying is it's just that I'm learning lessons from these programs about who I am as a member of this political community. And those lessons tell me I don't really matter. So I might as well just leave politics alone.
Oh.
Are we done?
Hi, Professor.
We have one more.
I had one more here. Hi, Professor Michener. Thanks for the talk.
Hi, Ethan.
One of the truly insane things about Medicare is that senior citizens who want to be in long-term care can't get it through Medicare. They have to spend down their assets below the Medicaid poverty threshold in order to qualify for any long-term care. What I'm curious is, like, did you interview in your qualitative research anybody that kind of had that experience of having spent their money down so that they could qualify for poverty-based long-term care through Medicaid?
Oh, that's interesting. So I interviewed dual eligibles, so people who have Medicare and Medicaid. I don't know that I interviewed anybody in this category of dual eligibles, though. So relatively well-to-do dual eligibles who maybe had been middle class or even upper class or upper middle class, but had purposely spent down are often, sometimes they spend down their resources. Sometimes they find other ways of shielding or hiding their resources or passing them on to their family. I mean, there's a whole cottage industry of lawyers that help you, if you're relatively well off, figure out when to shed your resources so that you are outside of the 5-year look-back window. Medicaid says, when you come to apply for Medicaid, we're going to look back 5 years. And if you seem like you've been ditching resources during that time, like, we want to know where those went. And so middle class, upper middle class people literally have lawyers that are like, okay, you're about 75, you're in good health now, but it's not going to be for long. Now you start putting this money in trust for your children and other places where Medicaid can't get it, so that by the time you get to 80 and you need that nursing home, your kids don't have to worry about paying for it. Medicaid will pay for it. So what that means is we have this chunk of Medicaid constituents who are actually, and their families, who are actually pretty middle class, who aren't the kind of traditional Medicaid beneficiaries, but they also rely on the program. So I did interview Medicaid beneficiaries who were middle class. I didn't interview elderly, like dual eligible Medicaid, Medicare beneficiaries who were middle class. Most of those people, the people in that category I interviewed were quite poor. And it's too much to talk about the difference between the experiences that Medicaid beneficiaries who came from middle class backgrounds and maybe were there because, so one woman who I feature quite a bit in the book, she had a son who had a very severe illness, right? It was her 4th child. She was like she was actually head of a hospital unit, and her husband, they're really upper middle class people. And then she has this son who has medical issues that cost upwards of $1 million a year. And so they have to engage Medicaid. There's no other option. And she looks completely different than the other Medicaid beneficiaries so these folks, like, I didn't interview anyone in your exact category, but when you're coming from a different class background, the way that you understand these things are completely different. And in the book, she's someone who's super active. There's a point where I think, well, what do engaged Medicaid beneficiaries look like? It's not like everyone across the board their political behavior is just dampened. So what about, under what conditions are Medicaid beneficiaries actually engaging in politics? Almost all of the people I could track down like this were people who were relatively well educated and who had some pretty strong connection to the middle class, if not being members of it themselves, right? And so it's not that these processes affect everyone in the same way. It really depends on where you fall in the broader social structure in terms of class and race, which may or may not have answered your question, but.
Let's give Dr. Michener